Today, we're diving into the neuroscience of ADHD, exploring what the latest research tells us about the ADHD brain from neurotransmitters to neural networks. So, let's begin. ADHD is not a problem in just one or two brain areas. It's a brain-wide condition involving multiple interconnected networks, and recent studies have emphasized this shift in thinking. So rather than looking for a single ADHD region, scientists now understand that ADHD involves disruptions across distributed neurocircuits, that is, networks of brain regions that work together to control attention, behavior, and motivation. The key networks implicated in ADHD include the default mode network, which is involved in mind wandering and internal thought, the dorsal and ventral attention networks, which are involved in attention, the salience network, which helps you decide what's important to pay attention to, the frontostriatal circuits, which connects the frontal cortex to the basal ganglia, that is critical for executive function and motor control, and also the mesolimbic dopamine system, which processes reward and motivation. When these networks do not communicate properly or when they are over or underactive, you get the symptoms we see in ADHD, such as inattention, impulsivity, hyperactivity, and difficulties with motivation and emotional regulation. Let's now look at various neuroscientific aspects of ADHD. First, we'll begin with brain structure. Magnetic resonance imaging or MRI studies have revealed consistent differences in the brains of people with ADHD compared to those without the condition. Reduced gray matter volume has been found in several key regions, including the prefrontal cortex, the basal ganglia, the anterior cingulate cortex, and the cerebellum. These are all areas involved in executive function, motor control, and attention. In addition, a landmark study found that youth with ADHD reach peak cortical thickness, which is a marker of brain development, about 2 to 3 years later than their peers, particularly in the prefrontal cortex. This suggests that ADHD may involve a delay in normal brain development, not just a fixed deficit. White matter differences have also been identified. White matter is the brain's wiring, that is the connections between different regions. Diffusion tensor imaging, a imaging tool that allows us to visualize white matter tract, have shown abnormalities in white matter integrity in ADHD, particularly in the frontostriatal cerebellar circuits, the corpus callosum, and the cingulum. These disruptions may explain why different brain networks don't communicate as efficiently in ADHD. Importantly, these structural differences are subtle and variable. They are not present in every person with ADHD and they can't be used to diagnose the condition, but they give us important clues about the underlying neurobiology. Now, let's talk about brain function. What happens when people with ADHD perform cognitive tasks or when they rest quietly? Functional MRI studies, which is used to assess brain function in response to activities, have consistently shown reduced activation in key brain regions during tasks related to inhibition and attention. A 2013 meta-analysis found that people with ADHD show underactivation in the following regions: the right inferior frontal cortex, the supplementary motor area, and the anterior cingulate cortex during inhibition tasks such as stopping or resisting distractions. This meta-analysis also found underactivation in the dorsolateral prefrontal cortex, the parietal cortex, and the cerebellum during attention tasks like sustaining focus or switching between procedures. These findings suggest that ADHD involves two distinct but parallel frontal-basal ganglia networks, one for inhibition and one for attention, both showing reduced activity. But there's another essential finding, that is that the default mode network doesn't turn off properly in ADHD. The default mode network is active when you're daydreaming or when you're thinking about yourself. It's your brain's idle mode. Normally, when you need to focus on a task, the default mode network quiets down and task positive networks take over. The task positive networks are regions of the brain that become active during attention related or goal directed processes such as planning and problem solving. In ADHD, the default mode network stays too active during tasks, interfering with attention networks. This creates a pattern of hypo-engaged task positive networks and hyper-engaged task negative networks. Essentially, the brain struggles to switch from idle to focus mode. This may explain the distractibility and mind wandering you sometimes see in ADHD. At the chemical level, ADHD is fundamentally a disorder of dopamine and norepinephrine regulation. Dopamine is a neurotransmitter critical for motivation, reward processing, attention, and motor control. In ADHD, there is evidence of reduced dopamine signaling, particularly in the prefrontal cortex and the striatum. PET and SPECT imaging studies show increased dopamine transporter density in the striatum, meaning that dopamine gets cleared away too quickly, reducing its availability. The mesolimbic dopamine system, which connects the midbrain to the striatum and prefrontal cortex, is especially important. This system processes rewards and motivated behavior. In ADHD, abnormalities in this circuit may explain why people with ADHD often struggle with delayed gratification, have difficulty staying motivated for long-term goals, and why they may respond differently to rewards and punishments. Norepinephrine is another key player. It's involved in arousal, alertness, and attention. Research suggests that norepinephrine enhances signals in the prefrontal cortex through alpha 2A receptors, which in principle helps you focus on what's important. In ADHD, this system may be dysregulated, leading to difficulties maintaining optimal arousal and attention. Here's an interesting finding. Stimulant medications, the most effective treatment for ADHD, work by increasing dopamine and norepinephrine in the brain. They block the reuptake of these neurotransmitters, making dopamine and norepinephrine more available in the synapse. This optimizes prefrontal cortex function, improving attention, impulse control, and executive function. Non-stimulant medications like atomoxetine work primarily on norepinephrine, while others like guanfacine directly stimulate alpha-2A receptors in the prefrontal cortex. One of the most important recent insights into ADHD is the state regulation theory, the idea that people with ADHD have difficulty regulating level of arousal and alertness. ADHD symptoms aren't constant. They vary dramatically depending on the situation. People with ADHD often perform much worse on long, boring, repetitive activities than on brief, engaging, stimulating ones. This isn't about effort or motivation. It's about the brain's ability to maintain an optimal state of arousal. Research shows that people with ADHD make more mistakes under two conditions. When things are happening too slowly, that is when they're under aroused, or when things are happening very fast, when they're over aroused. This suggests that the ADHD brain struggles to find and maintain the sweet spot of arousal needed for optimal performance. This also explains why some people with ADHD seem to thrive in high pressure, fast paced environments. The external stimulation helps compensate for their brain's difficulty generating internal arousal. Conversely, low stimulation environments like sitting through a long, boring lecture can be torture because the brain can't maintain alertness. The arousal dysregulation in ADHD likely involves both dopamine and norepinephrine systems as well as autonomic nervous system function. Some research suggests that people with ADHD have altered heart rate variability and other markers of autonomic dysregulation, which further supports the state regulation theory. ADHD is highly heterogeneous. There is no single ADHD brain, meaning it presents differently from person to person, both behaviorally and neurobiologically. Some people with ADHD have prominent executive function deficits. Others have motivational or emotional regulation challenges. Some have predominant inattentive symptoms. Some have predominant hyperactivity symptoms. Some have a combined presentation. Some show clear structural brain differences, while others don't. This heterogeneity has made it incredibly difficult to identify a single biomarker or brain signature for ADHD. Studies have emphasized that ADHD likely has multiple etiologies, different pathways that lead to similar symptoms. Genetic factors, environmental influences, and developmental timing all contribute to this variability. This is why ADHD diagnosis remains clinical, based on symptoms, and functional impairment rather than brain scans or blood tests. While neuroimaging has taught us a tremendous amount about the neurobiology of ADHD, we're not yet at the point where we can use brain imaging to diagnose individual patients. Now, let's recap what we've learned so far about the neuroscience of ADHD. One, ADHD is a brain-wide condition involving multiple interconnected networks, not just one or two brain regions. Two, there are structural differences in the ADHD brain, including reduced gray matter volume in various regions, plus delayed cortical maturation, and white matter abnormalities. Three, there are also functional differences, which include underactivation of frontostriatal and parietal networks during inhibition and attention tasks. In addition, there is poor deactivation of the default mode network. For dopamine and norepinephrine dysregulation in the prefrontal cortex and the mesolimbic system underlie many ADHD symptoms and explain why stimulant medications are effective. 5. Arousal dysregulation explains why ADHD symptoms vary so much depending on the situation and the level of stimulation. And 6. ADHD is heterogeneous. There is no single ADHD brain, and the condition likely has multiple underlying causes. Understanding the neuroscience of ADHD is important as it helps us see the disorder for what it really is. It's a legitimate neurodevelopmental condition with real biological underpinnings, and this understanding is helping pave the way for better treatments and support. Thank you for watching. If you found this video helpful, please like, subscribe, and share. See you next time.